Now for the analytic studies, now as I said before, you have your outcome of interest, you have your exposure of interest. They can either be observational studies or interventional. Observation, we're just observing what's going on. But interventional, experimental is where the researcher introduces an intervention, whether it's a drug, whether it's a program, a prevention program, an education program. When we say intervention, that's what it means. Then for observational studies, again, if you're looking at grouped data, it's an ecological study. But if you're looking at individual data, then you either have cross-sectional, cohort, and case control. You'll see cross-sectional is here, and it's also here, because sometimes in a cross-sectional study, you can just be looking for your outcome of interest. But sometimes in a cross-sectional study, you're collecting data on the outcome of interest and also the exposure. And the moment that you collect on the two, then it becomes an analytic cross-sectional study rather than just a descriptive cross-sectional study. But we'll go into these in more detail as we go along. Okay, so descriptive studies, when you look at the hierarchy of evidence, descriptive studies aren't very high, but they still have their use. So for example, somebody can publish a case series. You see patients with a particular characteristic and you publish it. So that's not very strong evidence, but it does have its utility. So around the 1980s, there's a doctor who noticed that there are some men who have sex with men who came with pneumocystis carinii pneumonia. And that was the first indication that, AIDS, of the syndrome of AIDS. So case series have their utility, but when we look at the strength of the evidence they provide, it's not very strong. But at least it can give us an indication that something is going on here and we need to do more studies. Now, an ecological study, now this one is where the measure of exposure is assigned to a population group. So it can be over time or in different areas. So I'll give the example here of where this is the incidence rate of breast cancer per 100,000 women, and then the intake of fat calories, and then the different countries. And we see that the more fat calorie intake increases, then the rates of breast cancer increase. But then we need to be careful when we are looking at ecological data, because it doesn't necessarily mean that the woman who had breast cancer in that population is the one who had higher fat intake. Because we are talking about population level data, we're not talking about individual level data. So that's what we call the ecological fallacy, when members of a group are ascribed characteristics that they in fact do not possess. So now, here we just assume that it's women who have higher fat intake who have breast cancer, but it might not necessarily be true. And there's an old example that people like to use about a researcher. He was writing his observations, and he said over 100 years ago that there seemed to be a positive association between the proportion of Protestants in a region and the rate of suicide. So if you had that, there are many ways you could interpret it. Somebody could say, well, the more Protestants you have, the more the suicides you have is the Protestants who are killing themselves. But then somebody else could argue, well, the more Protestants you have, maybe the Catholics are feeling isolated, and it's the Catholics who are committing suicide. So we have to be careful about grouped data, that we don't ascribe a characteristic to an individual based on group statistics. So it's not enough, but it gives us an indication that maybe we need to explore this more. So just to make sure it's sunk in, I'll need you to answer these questions for me. So a study was set up to investigate the effects of air pollution on infant mortality across different countries. So national infant mortality rates in 2023 were plotted against the levels of air pollution in the same year for 15 countries. What type of study design is this? It's an analytic one, but which type of study? Are we individual? Great, ecological. What's the study population?
Infants in 15 countries.
Okay. What's the primary outcome? What's the infant mortality rate? What's the primary exposure? Okay. What is the measure of disease outcome or occurrence? The mortality rates, yeah? Yeah. Okay, great. So now we've talked about descriptive studies. We're done with that. We've talked about ecological. Now we're going into the meat of observational studies, and we'll go through these in more detail. So cross-sectional studies, we are collecting information at a point in time. And one thing to take care of in cross-sectional studies, we can't, that relationship between exposure and outcome, we cannot conclude, we can't really be sure about it. So for example, you find somebody, let's say, who's underweight or overweight, and they're depressed. You can't tell, is it because they were depressed that they became underweight or overweight? Or is it because they were overweight or underweight that they became depressed? So typically in cross-sectional studies, we talk about associations, but we don't really say that, oh, it was the weight that caused the depression or the depression that caused somebody to be overweight or underweight. We just say depression was associated with being overweight, but we can't talk about the temporal relationship, that which one came before the others. But it gives us an indication where we could do more study. Yeah. So we are careful not to draw causal inferences. We also have to keep in mind, sometimes when the exposure happened a long time ago, people may not remember. So there's a risk of information bias. So we know that once somebody gets hepatitis B, by the time they develop liver cancer, is 40 years. So would somebody remember that 40 years ago I had yellowing of the eyes? Yeah? So those are some of the limitations with cross-sectional studies. Then, also we need to be careful about the sample size and our sampling procedure. If our sample size is too little, then it's not representative of the general population. And if we don't pick a random sample, again, it is not representative of the general population. So those are things to keep in mind with cross-sectional studies. Also, when we're talking about an analytic cross-sectional study, then we have 4 possible outcomes. There are those people who have the exposure, and they either have the disease or they don't have the disease. And there are those people who don't have the exposure, and they either have the disease and they don't have the disease. So let's keep that in mind as we start looking at the calculations we can do for cross-sectional studies. So in cross-sectional studies, we can measure the frequency of the outcome or the exposure in the population. So we can either look at the prevalence of the disease, what proportion of people have breast cancer, or we can look at the prevalence of the exposure. What proportion of people are using, let's say, contraceptive pills, oral contraceptive pills. So now just to make sure that it's settled in, can someone please tell me how would you calculate the prevalence of exposure among the people with disease? Using these letters. How do you calculate it? Prevalence of exposure among people with disease. Okay, we have A over? Well done. Prevalence of exposure in the people without disease?
B over D.
Yes, exactly. And then prevalence of disease in the exposed? I was giving the answer. A over? A plus B. Great. And then prevalence of disease in the unexposed?
C over C plus D.
Yeah, perfect. So cross-sectional studies, in the end, the basics of it, when you read papers, this is what they're going to talk about. So I'll talk a little bit about point prevalence and period prevalence. So if we are doing a study and we are, let's say, collecting information now, what proportion of people have malaria, that's a point prevalence. But if we are collecting information over, let's say, a year, then that's the period prevalence. And in that case, for the denominator, we'll use the average or mid-interval population. So the population at the midpoint of that year. And then a measure of effect is a prevalence ratio. So we can look at the prevalence of disease in the exposed and then divide by the prevalence of disease in the unexposed. And you can do the same for the exposure. So now, just for it to sink in, so the prevalence of smoking in a population was found to be 33% in men and 3.8% in women. Smoking was the outcome, gender is the exposure. What's the prevalence ratio for tobacco smoking? What would we do to calculate this? Sorry, I made this is the smoking should be the outcome. Smoking is the exposure. Sorry. Smoking is the exposure, gender is the outcome. Okay? No. Smoking is the outcome, gender is the exposure. Correct. So the prevalence of smoking in our population was 33.1% in men and 3.8% in women. So the prevalence ratio would be? Yes, you got it. So the prevalence of outcome in the exposed, the prevalence of outcome in the unexposed. So I should say, instead of saying gender is the exposed, maybe I should have said male or something. Prevalence of outcome in the exposed, prevalence of smoking in males over prevalence of smoking in females. And? No. Okay. Slower? Okay. The prevalence of smoking in our population was found to be 33% in men and 4% in women. So the prevalence ratio is the prevalence of disease in, let's say, the exposed group. In our case, it's gender. We'll say male, over prevalence in the not exposed group. In our case, maybe it's female. So maybe instead of gender, perhaps I should have used, let's say, education level. So maybe we could have said the prevalence of smoking in a population was found to be 33% in people with university education and 3% in people without university education. So what's the prevalence ratio?
A question first. So the prevalence of outcome in the unexposed. Is it the way
Yes.
3.1?
Yes. So prevalence of outcome in the exposed, let's change this from men, let's say education level, university education. So prevalence of outcome in people with university education is 33%. Then prevalence of smoking in people without university education is 3.8%. Is that better?
Yes.
Okay, so I'll change this from gender to something. So the prevalence ratio for tobacco smoking is 8.7. So people with university education were 8 times more likely to smoke than people without university education in this population. That's what it means. So now, a study investigated the association between trachoma, which is an eye infection caused by bacteria, and overcrowding. All individuals in one community were examined over the period of 1 week for the presence of trachoma. Following examination, members of the community filled in a questionnaire about the size of their homes and the number of people living in it. What is the study design? Is it descriptive or analytic? Great. Your teacher's pet, eh? So what is the study population? Yes, people in the community. What is the primary outcome? The trachoma. What is the primary exposure? Okay. What is the primary exposure? Overcrowding. Yeah? Because we are asking here the size of their homes and the number of people living in it. Yeah? And even the answer is right here. Okay. What is the measure of disease occurrence? The prevalence of trachoma, perhaps in all households, and then in those with overcrowding and those without overcrowding. And what could be the measure of effects? So now this one is the prevalence ratio. The prevalence ratio. So we'd say people with overcrowding are 3 times more likely to have trachoma, eye infection, than those without. So we are doing very well. We are now going to move to these other ones: cohort, case control, and then clinical trials. Okay, so the thing about a cohort study is we first start off with people by knowing somebody's exposure status, whether they're exposed or unexposed. Then we follow them up over a period of time to see if they develop the outcome of interest, whether it's a disease or whatever it is. So you can have a group of smokers, non-smokers. You follow them up for several years to determine whether they develop lung cancer, whether they develop bronchitis, whether they have peripheral artery disease. So that's basically what our cohort study is. We're starting with exposure, then we are following people up over time to check if they get the disease. This is just another way of looking at it. So people with the exposure could either develop the disease or they don't develop the disease. And people without the exposure can either develop the disease or they don't develop it. Okay, so what we do in a cohort study, you determine the person with the exposure, those without, you follow them over a period of time, and then you calculate the risks or rates of disease, and you also calculate the risk ratio or the rate ratio. Now that's our measure of effect. Our measure of disease frequency is the risk or rate, but our measure of effect is the risk ratio or the rate ratio. So things to take note of in a cohort study. Sometimes when you know somebody has been exposed, the way you collect information from them is slightly different. Yeah. So if we know, let's say somebody was working in a coal mine, somebody else was not, and then you're collecting information about, let's say, problems with coughing. If you know somebody was working in a coal mine, you might be very keen when you're asking those questions about coughing. Or have you had problems with coughing over the last year? If you know somebody is a coal miner, because you're expecting it, the way you collect information may be different. So those are some of the concerns we have with cohort studies. Because we know somebody's exposure, sometimes us as the researchers, we could be biased in the way we collect information. Then sometimes, when you're following up people for a long period of time, and let's say the outcome is death, you may lose these people, you lose them from the study, and it may occur differently depending on whether somebody was exposed or not exposed. So let's say if an exposure led to death, then you are following them up in Kenyatta Hospital. People, when they go to die, they go to the village to die, so you lose information about them, yeah? So those are some of the concerns about cohort studies, and that's why in cohort studies, people are very keen on the loss to follow-up. Like how many people were you left with at the end of your study period? Because the people you lost along the way, perhaps they developed the outcome of interest and you weren't able to detect it. And then there is also something that we call misclassification bias. If you don't measure the exposure correctly or you don't measure the outcome correctly, then it can lead to spurious results because you've classified somebody into the wrong group. Okay, so this, an advantage of a cohort study is you can focus on rare exposures. Because now you get these people with the exposure and then you follow them up over time. As opposed to you see in a case control study, where let's say you get somebody with a disease and then you want to look to see if they had an exposure. But if that exposure is very, very rare, then it's unlikely you'll be able to pick that up. So the good thing is, with a cohort study, you can pick up some rare exposures. And remember in the beginning I said you had smokers, non-smokers. You follow them up to see if they develop bronchitis, peripheral artery disease, so you can check multiple outcomes. Just follow people up and check for multiple outcomes. So we use a cohort study when you can define what that exposure is. Typically when the exposure is rare, we also don't want to wait too long. People say old people should not conduct cohort studies because you need to be there at the end, old researchers. So if you have a lot of time, sour, but ideally we don't want it to be such a long time. We don't want to be changing our PIs and all of that because maintaining that data over time also isn't that easy. And also we want something where the outcome, the time from exposure to outcome is close by because of those issues of loss to follow up, when you have to follow up a large group of people for a long time. Not that it doesn't happen, but it's so resource intensive that we need to bear that in mind. So if you don't have a long lifespan and you still want to do a cohort study, you can do a historical cohort. So in a historical cohort, you go to records and see whether somebody was exposed or not exposed. And then now you follow them up in time to see their outcome. So for example, let's look at, maybe if we knew there was a school that had a borehole that was contaminated, let's say with a particular mineral or something. Or chemical, something bad. We have records of the people who went to that school. Yeah? So instead of taking students now and following them up, we could go check the records of the students 20 years ago. Who are they? We know they were exposed to the water in this school, and then now we find those students and where they are now, and then see have they developed cancer or not. So a way of going around that concern about cohort studies taking so long is to undertake historical cohorts using records from the past. But importantly, in that past, what we're getting is the exposure first. Then we look to see if somebody developed the outcome. So the issue with this is sometimes records may be incomplete if you're looking at past exposure. So if you're looking at somebody smoking, it may be better to follow them up now and get information, okay, because smoking patterns change. You start with 1 pack a day, 1 cigarette, move to 1 pack, maybe 2 packs, maybe you go down. But when you're looking at a historical cohort, that level of detail as to how somebody was exposed, you might not fully be able to get it. So when we are looking at a cohort studies, what do we measure? We measure the cumulative incidence. Some people call it the attack rate or risk. So that is the number of new cases at the end of the follow-up period divided by the number of disease-free people at the start of the follow-up period. And we'll go through small exercises where we do them so it sinks in better. But when we are looking at person time rate, we're looking at the time of follow-up. So it would be number of new cases at the end of the follow-up period divided by the person time at risk. So the person time we follow them up. So if they're lost to follow-up, we haven't followed them And then from there, we can calculate a risk ratio or rate ratio. And the risk ratio is you talk about the incidence of disease in the exposed, okay, the incidence of lung cancer in those who smoke, and then incidence of disease in unexposed, the incidence of lung cancer in those who don't smoke. So that's what we are able to get from cohort studies. So since we did this one so well before, so this risk of disease in the exposed, so this is the people with exposure. So the risk of disease in exposed is A over A plus B. And the risk of disease in the unexposed is C over C plus D. And then our risk ratio is risk in exposed and risk in unexposed. Okay, so just to make sure we've all got it, there were 3 people who are observed in a study.
Could you go back to the explanation?
Okay.
The one before?
This one?
Yeah, the risk ratio.
Ah, okay. So this risk ratio, okay, so this is exactly this. So this risk, so here we've calculated the risk of disease in the exposed. We are okay with that? That these people had exposure. Let's say these people had smoking, they were smokers. These ones developed lung cancer, the disease is lung cancer. These ones do not have lung cancer. So the risk of lung cancer in the people who are smokers is A over A plus B. Are we together?
This one I understand. The previous is.
So this risk ratio is exactly this. So we are saying incidence of lung cancer amongst those who were smokers, and then incidence of lung cancer amongst those who were not smokers.
The number of new cases at end of follow-up divided by number of disease-free persons. Start of follow-up.
Okay.
Which is.
Oh, okay. So when we start the cohort, let's say we have the cohort of smokers. Let's say there are 100 people when we started off. At the end of the period, let's say we follow them up for 10 years, 3 people have lung cancer. So it is 3 divided by 100, the number of people who we started off with. So we started off with 100 people, we followed them up for 10 years. In that 10 years, only 3 people developed lung cancer. So our incidence is 3 divided by 100, 3 per 100. This one for person time rate is a one. Now I want us to do the exercise to better understand what it means to calculate the person time rate. You know, this one is it's easier to understand because we're talking about new cases and the number of people who we had at start of follow-up. But this one, we're talking about new cases divided by the time of follow-up, which is a bit like difficult to understand. But we've simplified it in this exercise. If we had 3 people in our cohort study, of course we would have 3, maybe we'll have 300. But if we were 3 people in our cohort study, one person, we're able to follow them up for 6 years. Then they are alive when they move away and they cannot be traced. The second person, we observe them for 4 years, then they die. The next person is observed for 10 years, and then they are alive when the study ends, because the study was only going for 10 years. Our outcome, we're looking at death. How many years of observation time at risk of the outcome do we have? So in this one, how many years? Next one we have? Next one? So in total we have 20 years of observation. Yeah. What is the rate of death? This one, they are alive when they move away, cannot be traced. This one person is observed for 4 years, then dies. This one person is observed for 10 years, they are alive when the study ends. So the outcome is death. How many deaths do we have?
One.
And how many years of observation time? Observation total. Yes, so we had 1 death per 20 person years. So that's how rate is different from risk. So if we were calculating the risk of death, it would have just been 1 divided by 3. Because we started with 3 people, 1 person died. So the risk of death, are there 4 people? No, there are 3 people. There are 3 people, then 1 died. So the number of deaths in that period was 1. The number of people who we started off was 3. So the risk is 1/3. But then when we come to the rate, we need to consider how much time did we follow this person for, these people for. And our rate now is 1 death per 20 person years. Yeah? Because we have 20 years of observation. And now this one also highlights, you see this person who was observed for 6 years, they are alive when they move away and they cannot be traced. They could have died or they didn't die. And that's the problem with cohort study and loss to follow-up. That this, perhaps, they developed our outcome of interest. Yeah? But at least when we are calculating rate, we take into account that we only follow them up for 6 years. They could have died in that additional 4 years. Okay. So, okay.
So what next to the follow-up is actually the calculation that we have done right now.
Yes.
What do you call it? The person years of follow-up.
Yes.
Okay.
Yeah.
So even if you don't know what happened there, it's an assumption.
Yes. So
that you make.
Yes. Oh no, we're not making an assumption. We're not taking it into account. You know, when we're saying risk of death, there were 3 people, and we are saying 1 died. But what if the second person, this one, also died, but they were lost to follow up? We don't know. But now, at least when we calculate the rate, which is about the time we observed people, it's like we censor that period. So it's like more accurate. Yeah, a more accurate measure. I think there was another question here.
Yeah. Just for this study, we assume like it was for these people, it was starting on different periods.
That's
or it was starting at the same period.
That's a really good one. So in a cohort study, let's say you can recruit this person in 2019, 2020, and 2021. Yeah? Because we are counting the time that we are observing them for. So it would be okay. And typically in a study, sometimes your recruitment, you don't necessarily start all at once. It's like you recruit people over a year or over 3 months, 4 months, and then you follow them up for a period of time. When we calculate the rates, it accounts for the fact that maybe this person, I only observed them, I enrolled them from 2019. This other person, I only did it from 2020. So that's a good thing about calculating person time, using person time as your denominator. So it's not a must that you enroll them at the same time. Sound? Yeah, so if, just to say, let's say this is the first person, this could be the second person, this person, and this is days. So even if you enrolled this person here, if you can define, let's say the number of months this took, let's say this was 24 months, this was 12 months, let's say this is 9 months, you're okay. But also, you could also start at the same time. And then, let's say this person you managed to go for 24 months, this one 18 months, this one 9 months. It's okay.
So when you start on the same, let's say the same timer, what would be the number of years.
Okay.
Assuming the three of them that started doing
At the same
period.
time, yeah. So for this one, if the one person is observed, let's call it, this one was 6 years. We followed them for 6 years. The second one is 4 years. Then this one, death. So I'll put a D here. But this one, we don't know what happened. It just disappeared. And then this one finished the 10 years. This, when we count it, is 20. But even if the first person, let's say we started at this time point, followed them up for 6 years. The second person, we started at this time point, followed them up for 4 years. This one, we started earliest, followed them up for 10 years. You see, in the end, our denominator is still the same, 20 years. Whether we started at the same time or whether they started at different time, it's this time of follow-up that matters. Okay, so back to our schematic, just to show where we are. Now we are moving here, case control studies. Okay, so in cohort, our starting point was, is somebody exposed or are they not exposed? In a case control, our starting point is, does somebody have the outcome, not the exposure, does somebody have the outcome or they don't have the outcome? So the starting point of a case control is the person with a disease or a particular condition. And then we need to select controls. So controls should be exactly like the cases, except they don't have the disease. And then we look back to see what exposures they had. So remember, cohort study, we started from here. Is somebody exposed, not exposed? And followed them up to see if they have disease, they don't have disease. But for case control, we start with, do people have the disease? Yes or no? Then we look back. Did they have the exposure or not? Very clear? Okay. So cases. So when you pick a case, let's say we've been using, let's say, lung cancer, you can pick a population-based case. So you go to the community and find people with lung cancer. Or you could go to the hospital and find people with lung cancer. Now, let's keep in mind about our healthcare seeking behavior in our setting. Sometimes, if you're doing a case control study and you pick your case from the hospital, you might be introducing some other issues because the lung cancer case who goes to hospital might be different from the lung cancer case who doesn't go to hospital. And if you're looking at exposures, then maybe now you're starting to mask some of your exposures because people who end up in health facilities, we have to keep in mind their access to health facilities and their care-seeking behavior. Because there was a time people were not going to hospital for cancer. They would go see the traditional medicine specialist. They would not go to the hospital. So if your study was on what are the risk factors associated with breast cancer, and you're only picking the people who end up in hospital, then the exposures you get may not be the true reflection of what the exposures are in the general population. Because you have a large group of, let's say, women who had breast cancer and who are not going to hospital. Sour. So, and that's why when you pick hospital-based cases, you could have issues. What I'm finding here, is it real or is it because of healthcare seeking or all of that? Okay, so the controls should be similar to the cases, except they don't have the outcome of interest. They don't have the disease. So in general, if you picked cases from the population, then pick your controls from the population. If you pick your cases from the hospital, pick your controls also from the hospital. And then there's a possibility of picking relatives, neighbors, people nominated by the case. But then there's the risk that that their exposures may be quite similar, and then it could mask whatever you're trying to uncover. Here, I also want to mention, let's say you're looking at exposure, you want to look at alcohol as a risk factor for pancreatitis. So you get your cases from the hospital, people who have pancreatitis. Then your controls, you pick people who are involved in a road traffic accident and from the same hospital. Now, you have to be careful how you pick your control to make sure the fact that somebody ended up as that control, they also weren't at risk of having that exposure. Because somebody who has a road traffic accident, maybe they were drinking. And now on this side, you're looking at pancreatitis. You want to explore alcohol as your exposure. But now you've picked a control, people who have been involved in road traffic accidents, and we know in our setting, road traffic accidents could be associated with alcohol use. So if you pick the wrong control, you will mask that effect, let's say, that alcohol has on pancreatitis. Because even in your controls, there was a higher exposure to alcohol than the general population. So those are some of the concerns about case control study, and you really have to think through who is the appropriate control for this case that I have. So you can increase the number of controls you have per case, and the good thing is when you do that, then it increases your precision. So your wide confidence intervals now start coming a bit closer. But if you go beyond 4 controls per case, then there's not much of a benefit. Then sometimes we talk about matching in a case control. So if you pick a case who is a female, you also want to pick a control who is a female. And then you can also perform that matching either at the individual level. I have one female here who was a case. I'm going to get a control who's a case. Or you could just say in general, my case says 30% were female, so I'll just make sure in my controls 30% were female. You could do it at the group level. So what is a nested case control study? So in a nested case control study, it's nested within a cohort. So remember a cohort, you identify them by their exposure, and then you followed them up to see if they developed the outcome, the disease. So now, when you're following them up, you have very good records. Because let's say if you're taking records of contraceptive use, maybe you're taking records of smoking, in a cohort, you're regularly meeting with your study participants and collecting that data. So now, when they develop the outcome of interest, whether it's cancer or whatever, you now can pick them as cases and then look back to see what their exposure was. Because you've been following them up for so long and you've been taking good records, then you can also have the advantage of nesting a case control within a cohort study. And the good thing about this is, you know how in a cross-sectional study, you didn't know which came first, the exposure or the outcome. But you see now in this one, since you've been following them up in the cohort, you know this person was exposed and didn't have the outcome. Exposed, didn't have, then they developed the outcome. And you can tell the exposure came before the outcome. So in a case control, what are some of the things we need to look at? We need to define our cases properly, because if you don't, you may pick people. So it's good to have like a definitive diagnosis. So if somebody has lung cancer or breast cancer, whether it's biopsy or whatever it is, make sure you have that confirmed diagnosis. Because I think it was mentioned yesterday how in our setting there are people who have been treated for cancer but they don't have cancer. So imagine including that person in your study, and they did have the disease. So in case control studies, when you're reviewing the study, make sure how they define that case. There's no room that they could have picked somebody who doesn't have the disease. Now, when you pick cases, let's say we're looking at breast cancer. You want to just go find all the women with breast cancer and then pick them in, put them in your case control study. The issue is those women who you pick, and let's say, just from society, like you just go into and pick. There are some of them who have had breast cancer for 10 years. There are some of them who have had cancer for 2 years. Yeah. So sometimes when you pick prevalent cases, which means existing cases and let's say new cases, when you do your analysis, the findings you get may be masked by the fact that those with prevalent cases maybe have they have survived for a longer period of time. So you could be getting different types of results. So it's better to pick incident cases. So somebody has just been diagnosed with breast cancer and you're enrolling them. As opposed to you go into the society, you pick a woman who has had breast cancer for 10 years, a woman who has had breast cancer 1 year, and you're putting them all together and trying to look at the exposure. The exposures you get, the risk factors, there could be risk factors for, let's say, a cancer with long-term survival versus risk factors for a cancer that somebody would die soon. So those are some of the concerns with case control study that we should keep in mind. And then also that in a case control study, typically when somebody has a disease, they are more likely to remember things. Like somebody who has breast cancer is more likely to remember how often or for how many years they took oral contraceptive pills versus somebody who doesn't have breast cancer. Because when somebody has that outcome, you think about it, you think about what could have led to this. So you remember, I had a boyfriend when I was 22 and I took it for a year. Versus another lady who's 70, maybe she also took contraceptive pills for a short time when she was 20-something, but she wouldn't remember because she didn't have breast cancer. So there's that issue of recall bias and people remembering differently depending on whether they are case or control. And then the issue that we talked about, if you pick the wrong type of control, it can lead to incorrect findings. So make sure that control also may not have that exposure that you want to look at. So the way you can go around sometimes getting past the limitations of a case control study is by having multiple control groups. So let's say you're looking at children with diarrhea in the hospital. You pick controls from within the hospital, so maybe children who are admitted for, let's say, burns, in the burns unit, but you also pick children in the community as a control. And then you do your analysis, and if your results are consistent across the groups, then you're more confident that this really was a risk factor. Because when you pick controls from the hospital and you pick controls from the community, this exposure was still coming up. And then also, because of the issues of recall bias, you might pick a control who doesn't have a disease, or you can pick a control that has a disease. Because that person who has a disease also may remember things more acutely than those who don't have a disease. And then, if your results are consistent, then you're more confident. And then the first one, living controls and dead controls. So if you, let's say, you can pick, let's say you have children who died from pneumonia in the hospital. You can pick, let's say, children who died from, let's say, meningitis in the hospital, and then you can also pick from children who are still alive, and then see as the controls whether you still get consistent results. So we pick a case control study when we want to look at the possible causes of the disease, the possible risk factors. Okay. So we prefer a case control study when the disease is rare, because just imagine, if a disease is very, very rare, if you have a cohort, you could enroll 6,000 people, but then none of them get the disease. But at least from the case control, you start off with the disease, and then you look back to see if they had an exposure, and you can look at several exposures. So in a case control study, what we calculate is the odds, which is slightly different from the risk and the rate. So the odds of exposure in cases, in this case, odds of exposure in case is what? A over A over C, because that's odds. So odds of exposure in cases is A over C. Before we would have said A over A plus C. Yeah. Odds of exposure in control is B over D, and then the odds ratio is you just put 1 over the other. We are almost done. So for this one, a study looked for an association between severe maternal anemia in late pregnancy and low birth weight in babies. All low birth weight babies born in a rural hospital were identified over 1 year. A representative group of babies without low birth weight were also selected over that year. For all these babies, the hospital antenatal records were used to obtain the hemoglobin levels of the mother in pregnancy. What is this study design? Who says so what? Yes, it's a case control. What is the study population? Let's say babies born in that hospital. What is the primary outcome? And the exposure? Perfect. Yeah. Exposure is maternal HB. Yeah. Okay. So now we're going to the final one. We're here, clinical trials. So, as I said previously, in a clinical trial, it's the researcher who allocates exposure to individuals or communities. And keep in mind, we cannot allocate a harmful exposure. It can only be a beneficial one. That's why for harmful exposures, we are using the case control, the cohort study to try and pick up what leads to disease. So for a randomized clinical trial, participants are randomly allocated to groups, those that receive treatment and those who don't receive treatment. And we do so to either test a specific causal hypothesis or to measure the effect of a particular intervention. So if we are measuring the efficacy in optimal conditions, then that's an explanatory trial. But a pragmatic trial is now in routine care. And this is the one policymakers are more interested in. When you give, let's say, cancer medication in a trial, there is so much support around the study participant that you can get this really great outcome. But then in a pragmatic trial, you say in routine care. Like now, if I was just to give it in KNH within the systems that we have, we might find that that effectiveness is not as high because maybe people are not adherent to the medication. Maybe there are issues to do with socioeconomic status. So maybe somebody can't eat, maybe it's got side effects, they don't have enough food, they won't take. So most policymakers are more interested in pragmatic trials, like in routine setting, what would be the effectiveness of this measure? And these are all of the things that we can evaluate, not just drugs, even we can look at medical devices, we can look at screening programs, behavior programs, all of that we can look at. And basically this is it. You randomly allocate, and then you check who improves, who doesn't improve, when we're looking at treatments.
So tell us more about the explanatory.
So explanatory trials is
An example.
so I'll say it is trials had in perfect conditions, which don't necessarily mimic real life conditions. So in a clinical trial, sometimes they will pay you to come. They will pay you actually to come for your visits. You will get called. If you get any sort of incidental illness, you will get treated. So it's not really real life. So we find that sometimes the settings of these trials in perfect condition are too perfect to a real world scenario. So the effectiveness you get in a explanatory trial, when you now, people should not get shocked when you now come to real life and you find it's not as effective. It's because the support around sometimes these clinical trials is unrealistic to real life. But that's basically what it is. So sometimes when you're reading a paper, they'll say a pragmatic trial. So it's like they put it in as part of routine care. They just maybe added the drug, but didn't add too much support around it, versus the explanatory trials where there's so much support, weekly calls, they're paid to come, all of that. It's like perfect conditions.
Which talks of efficacy, the other one talks of effectiveness.
Yes, yes.
I want you to.
Okay, so efficacy is, let's call it, is the effectiveness in a perfect setting, versus if effectiveness is now in real world setting. So for example, if you do the efficacy of the measles vaccine in a trial, let's say they say it's 90-something%. But when we come to Kenya and we are giving the measles vaccine to our children, our efficacy, let's say, it drops to 80-something%. Some children are malnourished. They don't mount a good enough immune response following vaccination. In real life, sometimes a child is, let's say, 8 months, they've come, measles vaccine is supposed to be given at 9 months in our setting. Maybe this healthcare worker says, this woman has really come from far. I can't send her back, to come back at in 1 month to take the measles vaccine. So sometimes we don't give the vaccine at exactly the recommended time. Maybe they give it a little bit earlier. So in a explanatory trial, these children will be given at exactly the right time. You have children who are perfectly healthy, but then in real life, you have children who have HIV. Some children are malnourished. Some children will come a little bit earlier. All of those, so in perfect setting, we'll call it vaccine efficacy of, let's say, 90-something% for measles vaccine. But the effectiveness in real world setting now is a bit lower because those other things come into play. It's not a perfect scenario. So that's the difference between efficacy and effectiveness. Efficacy is perfect setting, but effectiveness is now more in real world setting, given the different conditions that we could have. Yes?
Yeah, you mentioned that don't do harmful exposure trials. How will you know that harmful? Mentioned if you don't case control, right? So what if in the trial you actually realize it's harmful? And number two, subjects, also animals or mice.
Okay. So before it's tested on humans, then there's a preclinical studies which could be in animals, and you have to show the effect of the drug in animals to show that it's doing what it's supposed to do, and also you're taking note of adverse events. And then in clinical trials, there's a committee that is particularly looking at hazard and risk. So if you thought a drug was helpful, but then during a clinical trial you find that people who are taking it are having poorer outcomes, then what's that name of that committee? The data safety, is it board or what? Yeah, management board can even terminate it early. But ideally, before you use it in humans, you should have shown the mechanism of action is supposed to be like beneficial. You can't go straight just into humans without showing that.
The reason I'm asking, if you look at pre-COVID, number of deaths as a result of clots, okay, PET amongst others, in post-COVID, ideally, pathologists are noticing that post-COVID, there's a lot of clot-related types of deaths, strokes amongst others, right? But there is no one attributing to what you're there assuming. Right, like they ask you to think the boss, everybody has something in their head. They're going to have certain types of vaccines. And if you go back to how these vaccines were used, those processes, procedures, and trials that we're talking about, that's why I asked how do you know it's harmful?
Yeah, that's a really good question, and it's covered in this, the phases of a clinical trial. So before you take it to humans, studies in labs, studies in animal models, then you have phase 1, 2, 3. Typically after phase 3, that's when a drug is released into the market. But we're supposed to have phase 4, that when a drug or vaccine is released into the market, we continue to do surveillance for these possible adverse events. Now, I also have taken note of what seems to be an increase in clots amongst our population, and it seems to be in people in their 30s, so younger people than it was before. But, and this I believe is our shortcoming, we have not done a study. As we were told, even when the AstraZeneca vaccine came out, it seemed to be a higher risk of clots for a certain age group. But remember, that vaccine was not tested in our setting. And there are, differences between races when it comes to response to medication. So in our setting, if the pathologist or whoever it is, they can do a case control study. This person has got clots, this person has not got clots. You look back, because how sure are we it's the vaccine and not the infection with COVID that then later led to an increase in clots, if there really is an increase in clots. We are all postulating, but nobody has really quantified it. Because ideally, we should look at trends over time, see was there an increase, and then when there was an increase, was it amongst those who are vaccinated or not vaccinated? And then the risk is you cannot tell antibodies from vaccination versus antibodies from infection. So these are some of the concerns, but definitely it's something we need to do, and part of this phase 4 that we should be continuing to do in our setting. There are and the pharmacists here can tell us, there are several medications I think that have been released, then later on, due to this surveillance post authorization, you realize that there's an increase in clots, let's say amongst young women. So you send out a notice saying, take note of this to the medical practitioners, be careful when you're prescribing it, or you recall it. So definitely nothing is perfect. So just to keep in mind when you're reviewing a clinical trial, that why we blind, because we can. Oh, okay. So, okay, phases, before we get to humans, we do studies in the lab showing that it actually does what it's supposed to do, whether it's supposed to bind to a receptor or whatever it is. Then we move to studies in animal models. You see the effects, you also look at the good and the bad, the adverse effects, but also what it's supposed to do. So a phase 0 trial, sometimes this one, I don't think it's always done, but typically it would be in very few patients just to see how the drug is metabolized. Then once you go to phase 1, maybe 10 patients, you're looking at safety dosing. You're looking just at before you give it to more people. Then phase 2, now we're talking about 30 to 80 patients. You're looking at effectiveness now, and you're further evaluating your safety. And then phase 3 is now when we want to, let's say, compare it with other drugs in the market. Is it better than? Is it comparable to? But still, we are looking at safety. We continue to look at safety and effectiveness. And then now phase 4 is once it's out in the market, we are supposed to have done this work. So Tabitha is telling me I should close. So just to let you know, there are different types of study designs for a clinical trial. You can do before and after, so the same person before they got the drug and after they got the drug. You can have people cross over between 2 different types of treatment. And then what we saw with the Ebola vaccine in West Africa is a type of cluster randomized trial. It was a stepped wedge design that they roll out the Ebola vaccine in a particular area and then they move to the next one and to the next. So it's not randomized, but in the case of scenarios where you can't do randomization, then stepped wedge is like you're implementing, but as you're implementing, you're also collecting data on effectiveness and safety. Factorial, okay, so you can say, what if I give a woman nothing versus I give her iron during pregnancy versus I give her folate versus I give her iron and folate? Then you look at the effects in those different groups. Okay, I think when we come to the analysis, basically the same as we did before. Let's say risk of death in those who had the treatment, risk of death in those who didn't have it. And the analysis, there are 2 types of analysis. You know, somebody can be allocated to a particular group, but during the clinical trial, the clinician changes their medication. But you don't care about that. You analyze according to where they were allocated. So that's called intention to treat analysis. That's your primary analysis. But then, your secondary analysis is based on what people actually received. So only the people, let's say, who took the medication as prescribed. If somebody stopped it, you drop them from the analysis. But the problem is, now when you do that, you see how we randomized, we are losing the benefit of that randomization. Because before we started off, the 2 groups were pretty similar, but now when we do the analysis, the secondary analysis, based on what treatment people received, then we lose that benefit. So here is how you calculate the reduction in risk. So let's say if we're looking at a vaccine, you have the rate of disease in people who did not receive the vaccine, the rate in people who received the vaccine, and then the rate in people who didn't receive the vaccine. And that's how you calculate efficacy. Yeah? So just in summary, if you want to look at multiple outcomes, you look at the cohort study. You pick a cohort study. If you want to review multiple exposures, you look at a case control study. If the outcome is rare, case control studies and ecological studies are your best bets. And then just keeping in mind, intervention studies provide us with the strongest evidence that we can use. But beyond intervention studies is systematic reviews and meta-analysis, which Tono will be going through. So these are my last 2 slides. I was asked to just briefly, so that we are all on the same page about what a DALI is and what a QALY is. So DALIs, it's a measure of disease burden where you look at the time somebody has lived with a disability, and if that disease led them to die, the years of life lost. So if somebody, 1 DALI is 1 year lost of healthy life, 0 in this case means perfect health, and then 1 is death. And we're going to calculating it. So when you're looking at DALIs, to calculate it, you need to know the life expectancy. Sometimes you time discount, so you place more importance to life now as opposed to later. And then before, there used to be an emphasis on particular age groups that are being more important, but nowadays people don't do that. That's how you calculate your years of life lost, and then your years lived with disability, you use disability weight. So for example, chronic obstructive pulmonary disease is where somebody, the airways are restricted. You can have mild, moderate, or severe. So severe is even without doing much, you're coughing, you're wheezing, you're short of breath. But the mild one is you can walk for a while, then you get sick. So when you have mild COPD, this is the disability weight you're given. With moderate COPD, this is the disability weight. Severe COPD, this is what you get. So when you calculate the DALIs due to COPD for somebody who was diagnosed at 45 and ends up dying at 65, you'll say these are the years lived with disability. So you'll take that disability weight times the number of years lived with disability, and then you calculate the years of life lost. So let's say the life expectancy was 80 years, they died at 65, then now you calculate this, you come up with a summary measure. But this is if it was untreated. But if somebody is treated, they might live longer. So this years lived with disability is longer, and years of life lost is shorter. So ideally, your treatment will reduce your DALIs, because now you are able to live longer. Or this, if somebody had moderate COPD, treatment makes it mild COPD, so the disability rate is lower. And QALY is quality adjusted life year, so it's the opposite. So DALI is like a bad thing, but QALY is like a good thing. So we want to avert DALIs, we want to avoid DALIs, we want to reduce DALIs, but we want to gain QALYs. So QALY is perfect health is 1, and 0 is death. So just when it comes later on, we will have it. So I know it's an intense session, but the notes are going to be available online, and there's also a lot of people who already have this knowledge with them. Any question? Okay. So I think I'll call Tabitha because she's next. We're ready. Yes. So looking at how a test performs. Is that what you're referring to? So diagnostic studies, that's good. It's good you asked because it's coming in the next session, and Tabi will be going through everything. I think
Or a tip energizer. There was so much we have been here.
I know. How many minutes? 2 minutes, okay. 2 minutes, so we start at 10 sharp. That's okay. The content is come.
Many years ago, not in the classroom.
You have somebody who is not making you know. Okay. I think we are past 3 minutes now. We can settle down. We are behind on time, so hopefully we can catch up. And I'm happy that Dr. Jeanette is taking us through elaborate explanation of the study designs and measures of disease. So what I'm going to present on is a continuation of where she has taught. And mostly it's the application of what she was teaching us. One of us asked about measure of harm. She asked about how to measure harmful exposure. Yeah, and I will not dwell in it now. For the studies, you can focus on so many different things to interpret depending on what question you want answered. I will explain just a bit on that because you have asked it. But for the example I will give, I'm only going to focus on diagnostic studies. And if you have time, maybe you can look at therapeutic studies just shortly, if you have time. But I'll focus on the diagnostic studies and how we can use epidemiological evidence to interpret those. Can we settle in so we can start? Just there is. Then you have to be connected. You have to be connected. Can we go on? So, from our session with Dr. Jack in the morning, what can we summarize epidemiology as? Pardon?
Like a study of disease patterns,
Okay.
as well as health determinants. Study of patterns of disease and other health determinants.
So how disease is distributed, the pattern,
Yes,
and the risk.
in a population.
Okay. So you're looking at patterns, you're looking at causes of disease, the effects of those disease, how the diseases are distributed, what are the risk factors that expose someone to those diseases, and effectiveness of the interventions. So when you're doing like RCTs, you're looking at, you're testing if a therapy or a drug is going to work. Yes, this is to work. And what is health technology assessment from yesterday? Any attempts? Please look at me. Don't look down. Let's be together. Any attempts? What did you understand health technology assessment to be from yesterday? I encourage people not to say HTA. I encourage people to say the full word, health technology assessment. If you say HTA, sometimes you get lost in the abbreviation. So what is health technology assessment? Anyone? Volunteer? Yes? Any additional? Yes? Please.
Evaluation of interventions for purposes of making a decision on what option
Okay.
based on certain criteria.
Okay. You want to add something? Yes?
Yes, it's a process for ensuring that limited resources are allocated to uses that are greatest benefit to the society.
Okay. It's a multidisciplinary process. It is systematic, and it looks at health interventions. Yeah? Great. So when you're conducting health technology assessment, you consider burden of disease, you consider effectiveness of interventions, you consider the cost of that intervention, if it will be cost effective or not, you consider the budget impact of that intervention, and we look at equity and ethic issues, right? And the social impact as well. So how do we apply epidemiology to inform HTA decisions? From the morning session, we have looked at some of the measures that will be determined from our studies. Have we talked about prevalence? Yes. Incidences? Yes. So prevalence, we look at how common a disease is in the population. Morbidity, how does the disease impact the quality of life? I think Dr. Jeanette has mentioned a bit about DALIs, and she mentioned about CALIs. Yes. Tomorrow we'll also look at the measures of health outcome in detail. So we'll still go through whatever she has just mentioned in detail. So these are part of the information that we can get from epidemiological studies. Mortality, how many deaths are caused by a certain disease, and any new cases that occur within a period of time that you're interested in for a disease that you're looking at. And also quality adjusted life years and so many others. Life expectancy, any other health outcomes that you'd like to look at. We can determine them through epidemiological methods. So from the study designs that talked about in the morning, I did a quick summary of which best evidence you can use when you want to answer a question studies or cost-effectiveness studies. If you want to examine information or assess an intervention in terms of cost, if you are looking at a diagnosis, you want to answer a research question on diagnostic tests, for example, you look for diagnostic validation studies or prospective studies or blind comparison to gold standard studies. For etiology or harm, if you want to know, like number needed to harm or number needed to treat or risk factors, you look at cohort studies or case control studies, and I think it has been explained so well. I would not need to delve so much into that. Then if you want to look for prognosis, like sometimes a clinician would ask you, as a pharmacist, we have this patient, maybe a cancer patient, they're in stage 3 of a certain cancer, or stage 4. We are thinking of trying this medication on them. So you could tell them if it makes sense, like if the prognosis, what the prognosis would be by using that medication at an earlier stage or introducing it later. If, for example, a clinician wants to make a decision to either start a patient on dialysis or not, you can also determine the prognosis from published studies, epidemiological studies, and advise if it would add value for that if it add value to that patient to start them on dialysis, or you'll be spending more but you not add value or improve their quality of life in that sense. So that's what this kind of studies help us with. When you look at quality of life, you can use qualitative studies, and we will look at what those studies are and what methods are used tomorrow. And then for therapy, you can do systematic reviews or look for randomized controlled trial or single studies of randomized controlled trial to get evidence to answer therapeutic questions. So the type of questions in clinical practice cut across so many different things. I summarize them into diagnostic questions, etiology or causation questions, there's therapy or treatment, prognosis, there's also risk and harm. So you may need to determine like how many numbers are needed, like what is the risk of an intervention, the risk of an effect of introducing an intervention, or how many people you will need to be exposed to a certain intervention for them to develop a certain side effect. For example, I think the explanation that was being given in the morning, so if a disease has a side effect of, say, causing pain, or a cardiac event, for example, so you can determine number needed to harm or to cause that cardiac event. So if you're told number needed to harm is, say, 15, it means if you give that medication to 15 people, 1 in the 15 will develop the cardiac event. So those are numbers that you can actually calculate from studies. So if you have studies that look at the exposure of the events within the occurrence of the event within the exposed population versus occurrence of the event in the non-exposed population, so that's the risk of developing that cardiac event. Then you determine the attributable risk of developing the cardiac event within that population and use that calculate number needed to harm. Very many formulas, but just for you to know that you can actually determine that through calculation. So if you ask, okay, the COVID-19 vaccines, we are told they're causing harm, they're causing these side effects. So you give evidence for a decision maker that yes, they cause this event, but we need to vaccinate, say, 100,000 people to see one event or two events that have been reported within that population, for example, but you calculate that from the studies that have been provided. So the decision makers makes that decision. So what is the benefit? Is it beneficial to vaccinate 100,000 people and avert infection by this amount, but risk that one person or 2 people or whatever number of people may develop this event? Then they make that decision. I hope that's clear. Okay, so let's examine how we would use diagnostic studies to make a decision. So diagnostic studies or diagnostic tests focus is usually set on the performance of the test. So 2 main types of diagnostic studies. Sometimes we have, when we are conducting a test, we can either report that test as in a dichotomous way, so positive or negative, or we report it in a continuous scale. What kind of test do you think we report in a continuous scale? Any test that we report in a continuous scale? You can report sensitivity in a dichotomous way, but like what test? So we are in a clinical setting, we are conducting a test.
HIV,
blood pressure, blood sugar, temperature. How do we know that if we report a blood pressure of 100/80, how do we determine that now that means that's high or that's low or that's moderate? We have defined standards. Yes. So how did they reach the defined standard?
Maybe
Averages. Okay, we are going to explore that. So that's what we're going to look at. So 2 types of reporting, either in 2x2 tables for dichotomous reporting, that's positive or negative, like 2 ways of reporting, or if they're continuous scales, then we have the receiver operating characteristic analysis. So the choice will depend on whether the index test yields dichotomous or continuous results. And in this kind of test, gold standard is compared to the study test, and the gold standard is usually the reference test, and that indicates the truth, that is, whether the disease is present or not. So, and the study test in this case will try to estimate the reference test, the feasibility, the cost, and the safety.
I don't understand the receiver operating characteristic analysis.
We are going to explain to the end. Yeah, it's somewhere. So I'm just introducing. So for the receiver operating characteristic analysis is used for tests that are reported in continuous form. So how do we get, so for example, we have the standard and the documented standards of interpreting a test. That's the gold standard, for example. What if we are introducing a new diagnostic test? How do we determine that this test, at this mark, it will tell us that, yes, the disease is present, and at this mark we will interpret that a disease is absent. We'll need to compare the study test to the gold standard. What we already know tells us that there is actually disease when we test. And for tests that we report in a continuous way, we need to calculate the sensitivity and the specificity, and interpret that and plot that into a curve and get the area under the curve. And there's measured, there's standard ways of then interpreting that, you know, if we find an area under the curve that is within this range, then there's likelihood that this test is positive, and there's likelihood that it's negative. But I'll explain that as well. So this is what we mean by a 2x2 table. So for a 2x2 table, we have the reference test at the top here, and then is my cursor showing? We have the reference test at the top, and the reference tests we check for, if we use the reference test in people who have the disease, how many will tell us that the test is positive, like how many tests will come back positive in the disease. So we have 10 people who have the disease, if we use the reference test, will the test give us 10 positive results? Or will it give us 9 positive results, but one will turn negative, but the 10 people have the disease? So then if we have the reference test, we use it in 10 people, and 9 people turn, the 9 tests turn positive in the 10 people. That will be the true positive for that reference test. And then if one person turns negative, yet they have the disease, then we'll say that that's a false negative. But if we use the same test in 10 people who do not have the disease, you're healthy, you're just walking there like, oh, we're screening people, and you test positive for the disease, yet you actually don't have the disease, that will be a false positive. But if you test negative and you don't have the disease, that will be a true negative. And that's the same thing that we use for index tests. So when we are having a diagnostic test that we want to determine its performance, its sensitivity or specificity, its ability to give us an accurate result when we use it, we want to introduce a new test. For example, yesterday, I think one of the proposed tests was for the HPV screening. Yes, so if you want, what is the gold standard for HPV screening? Is it vaccine?
Let's say HPV.
Which one? Which of the HPV tests is there? There's the Viravili and there's the pap smear. Which is the gold standard for HPV testing? Or is it PCR? PCR is the gold standard. I don't know. I just know it's PCR. Yeah. So if we are going to make a recommendation for the HPV self-testing kits to be used, we are going to compare it with the PCR, which is the gold standard of the reference test. So if you're making a comparison, we'll look at how many people will be tested with the PCR, and actually the disease will be detected with the PCR. And then same thing with the testing kit, and check if there's a difference and look at what that difference will be. So we determine the sensitivity of that test, and if we introduce it, it will give us the result that we want, or it will give us false negative and we'll miss out on the cases until they are advanced in these complications. So we use, when you draw this 2x2 table, it will help you to determine a couple of things that you're going to look at. One of them will be the sensitivity of that test. So what is sensitivity? This is the proportion of those with the disease who actually have a positive test. That means that's the 9 people out of the 10. You remember the 10 people who had the disease, but only 9 were tested positive. And you can determine that from here. So that's 1 plus A plus A over A plus C, the total. So true positive over both true positive and false negative. That's everyone with the disease. Then the same 2x2 table, we can use it to determine the specificity of the test. That's the proportion of those without the disease who have a negative test. Remember the people who were just walking around and they were screening and they were being tested? So the ones who actually test negative because they don't have the disease. You can end up testing positive, yet you actually don't have the disease, and that's a false positive test. Then we have another measure called the positive predictive value. So we have the proportion of those with a positive test who have the disease. And negative predictive value is the proportion of those with a negative test who do not have the disease. So we are eliminating the false negatives in negative predictive value. And positive predictive value, we are eliminating the false positives. Then we have measure of accuracy, which is the proportion of accurate diagnostic test. So when you have a diagnostic test, like I explained, we're just going to answer if it's positive or negative. But for you to interpret, if someone asks you, okay, so do you think we should introduce this test in Kenya? You will not tell them, yes, this test is able to tell us there's a positive disease or not. We'll need to agree if we want to, if we're doing a screening test, do we want more positives or more negatives? More? We want the test to be able to pick anything that we think could be the disease we're looking for. So we want the diagnostic test to be sensitive, right? So if we are considering that test for a screening test, then you need to calculate and see, okay, what is the sensitivity of this diagnostic test? The higher the sensitivity for that diagnostic test, the better for you to recommend it for a screening test. Then if we are considering a diagnostic test for confirmatory, as a confirmatory test, what will you want it to tell you? Specificity. You want it to be as specific as possible. So sometimes, like, we look for the balance, but sometimes you find that for confirmatory tests, you will recommend tests that have higher specificity, and you may not so much concentrate on the sensitivity. So if the sensitivity is lower, then the specificity will not be a big deal. If you're looking for screening tests, then you want the sensitivity to be higher, and you won't really mind about if the sensitivity is slightly lower, the specificity is slightly lower. But the only way you can do that is if you're able to plot this 2x2 table and interpret those results from. So some studies will report the sensitivity and specificity, but you could be in a trial and you only have this number of positive, this number of negative. Gold standard, this number of positive, this number negative. And you should be able to then calculate what you're looking for. So if you're looking for the sensitivity or the specificity, you should be able to calculate from that or the accuracy. So those formulas are there. Then we have something called the positive likelihood ratio. So positive likelihood ratio is how many times more likely a positive test result is to be found in the disease compared to the non-diseased. So positive test in the diseased. That's which one? Is it sensitivity or specificity? Sensitivity. And then negative, and then so you compare that to positive test in non-diseased. That, what is that? Specificity. Yes. So you compare how many times more likely are we to get a positive test if you take diseased persons, then you compare that to a positive test in non-diseased. That's the false positive. So you get the positive likelihood ratio, and I will tell you why we need that. Then we have the negative likelihood ratio, which is how many times more likely a negative test will result is found among the disease. So that's false negative compared to the non-disease, which is the true negative. Sawa? Yes. Then we also have another measure known as diagnostic odds ratio, which is the overall measure of diagnostic test accuracy. And these ones, nimehesabu tu. But some of this information, so if you are looking for the positive likelihood ratio, and a study has reported only the sensitivity and the specificity, are we able to determine the positive likelihood ratio? Are we? I told you to look at me. Look at me, you will give me the answer. We are looking for a positive likelihood ratio. And we look for studies about a diagnostic test. And those studies have only reported the sensitivity or the specificity of those studies, of the diagnostic test. Are we able to determine the positive likelihood ratio?
Yes.
Exactly. So that's what I would like us to understand. So if you're looking for any of these properties, we should know that if a study hasn't reported them, we don't discard that study. There's actually methodologies to calculate. Yes. So let's see. I think I've explained how we determine. Yes. Let's go back.
For the positive likelihood ratio, the two formulas are not the same. One is sensitivity over specificity, but the second one is sensitivity over 1 minus specificity.
Okay. Okay. So this, I can't edit while presenting. Okay. So the sensitivity over 1 over specificity, this formula will actually use it when we are looking at the AUC. The ROC, area under the curve for the ROC. So I will explain as we go. Okay. So for the sensitivity and the specificity, this is just to highlight the calculations, how we get the true positive rates and the true negative rates. And then you have something called the positive predictive value. So for the positive predictive value, again, we want to predict that if the test is positive, what is the chance that someone actually has the disease? And this, we're still just looking at the performance of the test. And then if the test is negative, for the negative predictive value, if the test is negative, what are the chances that someone actually doesn't have the disease? And this helps us to explain, especially for diseases that are very sensitive and maybe has stigma. You want to, if you tell someone they are positive or their test has come back positive for that disease, it is actually really, truly positive. So for those kind of diseases, you'll want a high positive predictive value, right? Yes, so that you don't give someone a positive test and the stigma and they have some psychological torture and then it wasn't really true. Or for diseases that have maybe a bad prognosis or someone die really fast, you want to have a high negative predictive value. So that if you tell someone they don't have that disease and they go home and sit pretty, they don't show up 24 hours or 1 week later and they're dying, and it was a wrong diagnosis. Silvio? Yes? Yeah? Yeah. All right. So for predictive values are dependent on prevalence of the disease. And we say that with increase in prevalence, there will be increase in positive prediction, and there will be a decrease in negative prediction. So the chances that there will be the test will be negative for those who don't have the disease will be lower, because the disease is present anyway, as the prevalence is higher. Then this is the interpretation for the likelihood ratio. You remember the likelihood ratio that we were calculating? So what did we say the likelihood ratio is? What was the positive, what was the likelihood ratio? Positive and negative?
How many times a positive will actually be positive in a diseased patient?
Compared to the non-diseased. So we are looking for the likelihood that we have true positives among the all positives, right? So this is how you interpret it. So for likelihood ratios that are more than 10 or less than 0.1, this means that there's a large chance that that positive test will actually occur within the positives, those with the disease compared to the those without the disease. Is that a good or a bad thing? If there's a large chance that 10 people with the disease, if you test them, 9 of them will be positive, and they actually have the disease. And if we test 10 people without the disease, only 1 of them will test positive, and actually they don't have the disease. Like there's a high likelihood. Is that a good thing or a bad thing? A good thing or a bad thing? It's a good thing, because we want the test to tell us to pick the positives within those who have the disease. And if it was to give us a false positive, it should be as little as possible, right? Yes. So as the ratios go down, so the likelihood ratio between 5 to 10, that's moderate likelihood. So you'll want to probably look at other parameters for you to be sure that you want to recommend that test. Then for likelihood ratios that 2 to 5, that's the likelihood is very little, and you probably do not want to consider that test at all. All right. Do we want to take tea before we go on to the next one? I think we should. Will 15 minutes be enough? Then we'll resume at 11? Actually, 18 minutes. I think we have 18 minutes. I think that's enough. You can resume at 11, then I'll explain the receiver operating curve, characteristic curve, and how to analyze that for continuous tests. Is that okay? Yes. Please proceed for tea.
One